Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Michael Day. He's an orthopedic surgeon, and his Kevin MD article is titled Opioid-Free Orthopedic Surgery, Why and How My Patients Go Opioid-Free After Surgery. Michael, welcome to the show.
Thanks for having me, Kevin.
So we'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
Okay, so I'm a native Pennsylvanian, which is currently where I practice. I did my residency in orthopedic surgery in New York City. I was at NYU. And then I did a fellowship in sports medicine at Lenox Hill Hospital. And since I graduated from fellowship, I've been practicing in central Pennsylvania, working as an employed physician for a health system here. And that's how I got into the practice of sports medicine and specifically the opioid-free, which I know we're going to get into.
All right. So just tell me about some of the joys and challenges that you have practicing sports medicine or orthopedic surgery.
The joys, to start off with that, we have highly motivated patients. They have usually just one problem. That's a great appeal of orthopedic surgery in general. One problem that is often fixed on one day. And there's a lot that goes before that. There's a lot that goes after that. But there's a noticeable difference on that day of surgery where something that's broken is fixed, something that's ruptured is repaired, something that's not working is reconstructed. And you can see that transition and you can be a hands-on big part of that for a patient, and it's very gratifying. And when you have a motivated patient that's often otherwise healthy, not to say that some orthopedic patients don't have other comorbidities, but especially in sports medicine, we have a lot of healthy, motivated patients. So it makes it easy and rewarding to have a relationship with them and help them get back to mobility and back to sport. Challenges that we face are somewhat similar to what a lot of physicians are facing. External pressures from insurers that are dictating what we do to care for our patients, how we can do it, when we can do it, what's approved and authorized, either from their perspective as the payer or from the patient's perspective as someone that's facing out-of-pocket cost, access. And this is true in primary care as well as specialty care. And with us being in a rural area, it's especially difficult for us. We have nearest university center is more than an hour away. So we have specialists. We don't have all the specialists that we have. It's hard to get in to see them. I refer my patients to a rheumatologist or a neurologist. That's going to be a multi-month wait. So fortunately, as I said, the sports medicine patients, we have a relatively small group of consultants that we work with, but access all across the system is a challenge.
All right. Let's talk now about your Kevin MD article. It's titled Opioid-Free Orthopedic Surgery, Why and How My Patients Go Opioid-Free After Surgery. Now, for those of you who get a chance to read your article, just walk my audience through it and share the story why you decided to write it.
I finished my training about 5 years ago. So I was in medical school and in residency during the pain is the fifth vital sign era. And that was really harped on that we need to control the pain. We need to combat this. We need to do everything we can to get this as close as possible to zero. And in that era, that was a very pharmacologically driven approach. And that's how we handled it. And that was the mainstay of what we did. And as residents, we were often the writers of the prescriptions. And there's a lot of motivation to, for example, cover what's needed and avoid refills, avoid phone calls. So you would prescribe the maximum instead of the minimum to try and cover all bases. And
now, what would you mean by that? Cover the maximum and not the minimum?
So if there's a wide range of what a person after a particular surgery might take, some people are going to take few opioid pills and some people are going to take a lot. If you take the upper end of that and you prescribe based on that, then no one's going to need a refill. If you take the lower end of that and people are often exceeding that, then a lot of people will need refills. And then so you want to not be giving too little for the average person. Back then, we're not even measuring that, so we don't even know what's average. I think some of the data that's come out recently is giving us some more information to help us know what can be expected, what is normal, or at least average in different populations after different surgeries. So, I mean, we're familiar with the way that opioids are problematic, and so I started thinking about that in my practice. And it's something that you can't change it unless you're measuring it. So I picked a surgery that was generally considered in sports medicine to be painful, ACL reconstruction. And anecdotally, I had noticed that there was a wide range in what patients were experiencing and consuming in terms of their opioid requirements after that surgery. And I noticed that some patients took very few and some took a lot. So I started measuring that. I saw that a lot of times the patients that took few would take just one or two, maybe on the day of their first rehab appointment. And a lot of those patients were younger patients. So I thought, well, these are patients that we want to avoid opioid exposure to the developing brain. That's a good target for minimizing opioids and perhaps eliminating. So I chose to focus on the under 25 age group, which includes our high school and college athletes, which are very common ACL reconstruction patients. And found that on average, all comers were taking 13 oxycodone. So I immediately lowered from my standard 30 to 15. And then when I thought if some of these patients are taking one or two, there's a very short leap to zero. So let's pilot it with the under 25. And I did very little to my protocol, which was already a multimodal protocol, other than eliminating the opioid. But I think the key was then also talking about that with the patients and setting expectations and discussing reasons and the why and how of the opioid. I found that those patients did not need opioids. And despite my offer to prescribe them if and when they would need them as an emergency rescue prescription, I haven't had a single patient request that yet. So it's worked out very well.
So take us into that conversation. So in general, for this under 25 age group who undergo ACL reconstruction, what kind of pain, what kind of discomfort should they expect after a typical procedure like that?
And I think the individual experience of pain is pretty wide ranging, but in general, when I'm counseling them, I tell them that they're going to experience perhaps significant but manageable pain for about 2 days, worst during that first 24 hours after their local anesthetic and or nerve block wears off. It's usually not excruciating, not extreme, and importantly, I want them to understand that it's going to be treated in one way or another from my perspective, from the perspective of our treatment team, and that it's adjustable. We have a protocol, but we're also able to individualize treatment based on response to treatment and individual needs.
So what will be examples of non-opioid pain therapy in a typical scenario like this?
Typically, we'll have them start using TENS unit, transcutaneous electrical nerve stimulation, preoperatively and 2 days postoperatively. We'll have them meet with a physical therapist at least once preoperatively, and then usually on day 1 or 2 postoperatively. We'll, unless there's any contraindication, we'll initiate immediate weight bearing, which is counterintuitive but decreases pain. We will have the anesthesiologist give a nerve block. Usually it's an adductor canal block. We will supplement that with some local anesthetic. We will immediately start cryotherapy, or if access to the cryo unit is not available, just regular ice. And then pharmacologically, we will use a non-steroidal anti-inflammatory around the clock initially, acetaminophen around the clock initially, gabapentin in an off-label use as a co-analgesic to supplement that. And then the opioid is there as an option, but is not routinely prescribed. And so that's the general protocol of the multimodal protocol that we use. We also sometimes will use CBD, cannabidiol. Now that's something that is not routinely, it's not prescribed in the same way as those other medications and does represent additional cost, but it's another option that I routinely talk about with patients as a non-opioid kind of pharmacologic option.
So talk about some of the risks of short-term opioid therapy in this age group, just from your experience, or is there any data supporting some of the risks that we want to try to avoid?
Well, I remember in medical school in particular being taught you can't get addicted if you're consuming opioids as treatment for pain. If you used those receptors in response to pain that you wouldn't get addicted. And I think the data subsequent to that has shown that's unfortunately just not true, and that a lot of patients that end up abusing opioids, prescription opioids or otherwise, started off with their introduction to opioids was an orthopedic injury or other surgery, that they received opioids as a legitimate prescription from a doctor prescribing appropriately that wanted to treat their pain after an episode of acute pain. Unfortunately, that's the story for a lot of people that get introduced and ultimately end up having a trouble with an opioid abuse problem. So I think that data has changed over the last 5 to 10 years. And we also know that the developing brain is particularly at risk for the adverse effects of opioids. And so that is a population that we really want to decrease exposure, because we don't necessarily know who is going to have a problem. There are plenty of people that have acute injury, surgery, acute pain, use opioids, and it's just episodic. And there are certainly risk factors that we can identify: prior opioid use, prior addictions elsewhere, various social factors. We still don't know for sure who's going to have a problem just from a routine.
So, in your small cohort there, approximately what percentage of patients did not need opioids after their ACL reconstruction?
Well, since the initiation of this protocol, in the patients under 25 undergoing ACL reconstruction, it's 100% opioid free. So each patient offered to have a rescue prescription if needed, and no patient has utilized that.
Now, is this opioid-free approach in this procedure and in this age group, is that common among most orthopedic surgeons across the country, or is this somewhat unique?
I think it's gaining traction, but I think the majority across the country still utilizes some opioids. Certainly, there's been a trend to curtail prescribing practices. And from what I see in the literature, there's ranges of opioids consumed that are into the low teens, I would say, on average for ACL. There have been a couple randomized control trials that have compared opioid-free. What I see in a lot of the literature is that we'll often compare an opioid-free cohort that uses the NSAIDs, the acetaminophen, the gabapentin. Sometimes they'll include tramadol in an opioid-free, but acts on opioid receptors. Sometimes they'll include benzodiazepine, which is non-opioid, but has its own risk profile. And they'll compare that to a Percocet alone. And then they'll demonstrate superior with the opioid-free. And I think some of that is a little bit unfair because you're using the multimodal plus the opioid and comparing that to just a Percocet. Whereas, I think really you can isolate it down to the opioid. And I even found in my patients that paradoxically, or seemingly paradoxically, the pain scores were better with the opioid free when that was the only thing I changed. So we looked at our cohort, the 2-week visual analog scale pain score average was 2.7 in patients that had taken opioids prior to this, and average was 1.7 in the patients that were completely opioid free. And the only thing that had changed pharmacologically was the removal of oxycodone.
Are you looking to expand this opioid-free approach to other age groups and other procedures?
Yes, I have expanded it to all ACL reconstructions. So there are some patients that in my discussions with them will come to the determination that they would like an opioid prescription available. So it's not as normative as it with the younger cohort, where I say, we don't routinely prescribe this and we'll prescribe it if you need it. Some of the older patients they say, I think I'm going to need it. And we'd have that discussion and we prescribe it. But routine is not to use it for ACL reconstruction. And I've expanded it among that age cohort of under 25 to not using it for any surgeries. ACL is maybe more painful. I think periarticular osteotomy is probably the only procedure I do in a young person that is more painful than an ACL. I have not had a problem with expanding that to anyone under 25 that's having surgery with me, gets an opioid-free protocol. And then outside of that, I have not expanded it to the rotator cuff population. That's probably the other sports medicine big pain generator, and that tends to be an older patient population. And so that certainly is not opioid free in my practice at this point. It is trending towards fewer opioids used and also utilizes the same multimodal.
And what's the reaction to these opioid-free initiatives among your orthopedic colleagues?
Largely positive. I think there's some caution that is warranted in that we don't want to, in our zeal for minimizing or eliminating the risks associated with these, create shame or vilify anyone that is utilizing them as part of their practice, because they have a role and they are one tool in the toolkit. I think they should be kept in that perspective and relegated to that role. There's an appropriate caution where you say, hey, so and so is using opioids. We don't want to say this guy's bad for using opioids. And so I think there's a caution there. And there's also a little bit of reluctance among some of my colleagues. They say, well, agree with all this minimization, but I'm still just going to prescribe 5, because what about that one first night when the pain is the worst? And what if it hits them in the middle of the night and I want them to just have these 5 pills as a backup to the backup? And I think that's fine, because we're all see ourselves headed in the right direction, that this is a problem that we contributed to as prescribers historically. And the first step is just our awareness of our role in that. And I think we're starting to get a more universal awareness among orthopedic surgeons.
We're talking to Michael Day. He's an orthopedic surgeon, and we're talking about his Kevin MD article, Opioid-Free Orthopedic Surgery, Why and How My Patients Go Opioid-Free After Surgery. Michael, what are some of your take-home messages that you want to leave with the Kevin MD audience?
I think the most important take-home that I would offer from my experience is that there's a shared mindset between the surgeon and the patient, or even outside of surgery between the physician and the patient, that you can, to some extent, change and choose that mindset, and that can affect a patient's experience and outcome. And that's the thing I noticed with my transition to opioid free, was that I went from a mindset that this is a necessary evil for controlling pain for my patients after surgery so that they can achieve the outcome of having a repair or reconstruction, to this is not necessary. And I approach my patients with that mindset to say, what's normal is that we don't use this, and we can use it, but the normal thing is not to use it. And if you have that buy-in based on trust you've established with the patient, then you can totally change their experience of post-operative pain, because now they're expecting it to be not as bad. And when we're talking about pain, anticipation is the worst part of it, because everyone has survived all the pain that they've experienced. But what they are most concerned about is the pain that they've not yet experienced, and what's it going to be like, and how bad is it going to be. So if you start from a mindset of, 1, it's not going to be that bad, and 2, if it gets to be bad, we're going to change the plan and we're going to control it, then you're giving yourself a head start. You're starting on third base with that postoperative pain control.
Michael, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thanks for having me.